Okay, how we can utilize clinically recorded electrophysiological data to identify atrial cardiomyopathy in patients with atrial fibrillation. So as we all know, atrial fibrillation causes structural remodeling. And what does structural remodeling means that when the process of structural remodeling starts, then you get a significant increase in amount of connective tissue formation and fibrosis. So if you take a look at this slide, you see two pictures. So on the top, you see a histology of the goat atrial tissue with 3 weeks of atrial fibrillation. On the bottom, you see a goat with 6 months of atrial fibrillation. And if you compare these two pictures together, you can appreciate a significant increase in the white material. And this white material is nothing but the fibrosis and connective tissue. And we all know that connective tissue and fibrosis causes increase in the complexity of the conduction pattern in the atria. So they hampers conductions. So if you take a high resolution electrode and you just put it on those tissue and you start to map and record the electrical activity of those tissue, you see that in the presence of fibrosis, the conduction pattern become more and more complex. So if you compare the map, recorded map on the top and then to the one in the bottom, you can clearly see a significant increase in the conduction pattern complexity in terms of number of waves. So the waves on the top pattern is more broad and they just, and they are the pattern is far simpler compared to the one you see on the tissue with a higher amount of fibrosis. And this has been shown in several studies that the increase in amount of fibrosis and also structural remodeling causes increase in the complexity of the conduction pattern in patients with atrial fibrillation. So you see the number of waves which can be used to quantify complexity increase significantly in the persistent atrial fibrillation patients compared to the acute one. But the question is that how we can identify this. And identification of this area is very important because it can help the clinical outcome. So we can identify regions that can initiate, perpetuate, and also maintain atrial fibrillation. So if we can identify this region, we can significantly improve the clinical outcome. So voltage map has been used frequently to detect area with fibrosis. So basically, what it means is that if you put an electrode in an area which there is no fibrosis, you expect to see a very high amplitude on your recorded electrogram. And if you move to the area with the fibrosis, you expected to see a reduction in the amplitude of the electrogram. However, there is a couple of problems here because voltage maps are associated with pathophysiological factors and also measurement factors. So atrial wall thickness can affect the voltage of your recorded electrogram and presence of the pre-atrial fat also. And also action potential morphology can also hampers the voltage that you're recording. And also measurement factors like the catheter myocardium contact and the electrode size and spacing can affect your voltage, and more importantly, the wave direction. So what else can we do? So what's the alternative? So we can use conduction velocity. So we know that fibrosis can reduce conduction velocity in the tissue that the fibrosis present there. But calculating conduction velocity in an accurate way is challenging when you use clinically recorded data. And why is that? Because you have sparsity and distribution of the data. So we are not always lucky that we get high resolution data. Sometimes in the region that you want to calculate the conduction velocity, your data is very sparse and the resolution is completely low. So here you see an example. And since we want to calculate the conduction velocity for a region, we need a subset of electrograms data to calculate the conduction velocity. And if you're not lucky in that region, you don't get enough information how much you can rely on the conduction velocity you calculated on that region. And also, there are a certain level of uncertainties in the data that you recorded in a clinic. So for example, did your machine record the electrode locations in a very precise way? So how much is the error? So we can expect some errors when the electrode locations are detected. And then machines can make mistakes to detect the local activation time. So here in this slide, you can see an example of a recorded electrogram where the machine detected local activation time, not in a very precise way. So all of these errors exist during the mapping procedure, and if you want to use this data to analyze them later, may affect our result. So what's the aim of this study? So the aim of the study is to try to test different algorithms that exist for calculating conduction velocities, like a triangulation, polynomial surface fitting, and also radial basis function, and assess the performance in the presence of the different level of uncertainties that you have from the clinically recorded data. And how we did that, we use in silico studies, because with the in silico studies, we have a complete control of the environments that we are doing our study, and then we can use this one as a ground truth to compare the performance of each of these conduction velocity calculation methods in the presence of the different uncertainties. So what we did is that we took a left atrium of a patient with atrial fibrillation. We did the segmentation and we create a mesh from that. And having that, we just, with a known conduction velocity, we reconstructed the local activation time in silico. And what we did is that we paced at a certain location, we know the conductivities, and then we try to simulate the local activation time in the absence and also in the presence of the fibrosis. In order to avoid the artificial high conduction velocities due to the wave collisions, we use the divergence method to detect the regions with the wave collisions and to exclude those data from our conduction velocity data. So here you see an output of the algorithm that we use for the ground truth. So what you see here on the left, you see a reconstructed conduction velocity map in silico from in the presence and also in the absence of the fibrosis. So you see that how well the conduction velocity is distributed from a value of 0.2 to close to the 1 meter per second. And also in the presence of fibrosis, you see a bimodal shape that's the area, so the hump that you see in the low conduction velocity zone is sort of showing the fibrotic region, and the hump you see on the higher end, it shows the normal tissue. And the aim is that to see how the different algorithms for calculating conduction velocity can perform under certain uncertainties like a sampling data, a density, local activation time assignment, and spatial noise. So in order to test this, what we did is that we uniformly distributed sampling data points on our mesh, and we recorded the simulated local activation time, and then we gradually reduced the sampling point density to test how each of these algorithms works better to calculate the conduction velocity. And in order to test the local activation time assignments, we introduced a uniform noise with amplitude of like 20 milliseconds. And then we gradually increase the noise levels to the local activation time to see how these algorithms can react in the presence of the higher amount of noise in the local activation time. And also we introduce a spatial noise. So spatial noise is sort of mimic the scenarios that your electrode location has not been detected precisely by the mapping device. And what we did is that we simply introduce a Gaussian noise distribution to your electrode locations, and then we gradually increase that one. And then we tested each of these algorithm performance under these uncertainties. So here's the result. So with the triangulation, you can see in the scenario that you have a very high sampling density and no local activation time noise, no spatial noise, so everything is perfect condition. You see that triangulation works pretty well. So the ground truth, which is shown by the gray here, is the one that we got it from the gradient one, the one that I showed from the high resolution simulation data, and the red shows the triangulation method. And then in the perfect scenario, triangulation and the ground truth, they are matching very well. However, as soon as you start to increase the noise, you see that the triangulation methods start to show, to underestimate conduction velocity at some point, and also to artificially showing a high conduction velocity. And if you increase the noise further, then the triangulation method fails to find conduction velocities in a reliable way, and then you see a very low conduction velocity. So it's always underestimate the conduction velocities. And then also, if you want to use the divergence method to exclude the areas with the wave collisions, then you see that the gradient doesn't work if you start to increase the noise. And then you see that by increasing the noise, you have to exclude further and further and further the area of the tissue that you calculated your conduction velocity. What happens in the polynomial surface fitting? So polynomial surface fitting is not doing as a great job as a triangulation, even in the perfect scenario. So you can see and appreciate here that in the polynomial surface fitting, even in the perfect scenario that you have no noise and then you have a very high sampling data, you see that the polynomial surface fitting has a tendency to calculate the conduction velocity and underestimate the conduction velocities compared to the reality one. However, if you start to increase the noise, the performance of the polynomial surface fitting started to increase to a certain extent. And then if you look at the middle one, the middle column here, you see that we had a medium level of the noise in local activation time and the spatial noise. And then the polynomial surface fitting shows some artificially high conduction velocity. However, the majority of the conduction velocity points calculated by the polynomial surface fitting fits with the ground truth. But if you increase the noise to a higher level, again, the polynomial surface fitting fails to calculate the conduction velocity in a reliable way and has a tendency to underestimate the conduction velocity. And the third method that we used is the RBF, so radial basis function. So radial basis function is you simply get the local activation time recorded from the electrode locations. You have to project it on a mesh. And when you project the local activation time on the mesh and then you do the interpolation, then you just simply calculate the gradients of the local activation time propagation on the mesh surface, and then you use the radial basis function for the interpolation, and then you calculate the conduction velocity. And then because that you project the data to the mesh surface, if you have a good mesh and then the surface is nice and smooth, radial basis function works fine in all scenarios. However, if you have a high noise level, it starts to sort of underestimate the conduction velocity. But as you can see here, the radial basis function works pretty well in the presence of the higher amount of noise and also in the procedure to calculate the divergence and also exclude the artificial high conduction velocity due to the wave collisions. So far, we assessed the performance of these three algorithms to calculate the conduction velocity, but our question was that how we can identify the fibrosis using the conduction velocity method. So what you see in here is the ground truth method. So the ground truth, if you remember, that was the one that we did on a high resolution simulated local activation time with the highest sampling density possible, and we use the gradient method. And then you see, and even in the ground truth, using conduction velocity to identify fibrotic region, we come with the accuracy of 82%. So we could not go further than that. And what happens if you use the triangulation method? So the triangulation method did a pretty fair job to identify fibrotic regions in the time that we have very high sampling density, we have no local activation time noise and no spatial noise. But you can see the performance start to drop and drop, as we expected, because triangulation had a tendency to underestimate the conduction velocity. And underestimation the local conduction velocity caused a false detection of fibrosis, because it's basically on those regions that you expect to have a high conduction velocity. When your calculated conduction velocity is low, it just detected as a fibrotic one. And this is the same scenario with the polynomial surface fitting. So with no high sampling density, no noise in the local activation time, spatial noise, polynomial surface fitting works pretty well. But as soon as you start to increase the noise level, then it fails to detect the fibrosis regions in a precise way. And on the radial basis function was the best to detect the fibrosis location in the absence of any noise and in high sampling. And it kept the performance when you increase the noise level. But then again, when we go to the very high level of noise, the right radial basis function also fails. So this gives a message to the clinicians that we can detect fibrosis, but to a certain precision. So we have to be careful when we want to use the conduction velocity to calculate the fibrosis about the resolution of the data that we have, the amount of noise, possible noise from the clinical data. But to conclude from this presentation here, radial basis functions show the best performance for detecting correct conduction velocity and also fibrosis in the noise control. So in the noise encounter during the clinical exoanatomic mapping. In the absence of the noise, all algorithm works perfectly. So we have to be careful that if we want to select our algorithm, we have to be careful that what's the noise level and which algorithm we should track. And the triangulation method was the best ability, had the best ability to identify slow conduction of fibrotic lesions in the absence of the noise. So by this, I would like to conclude my presentation. I also like to thank you all, and thank you.
So, thank you, Dr. Gharaviri. It's a very important, impressive presentation. The data. Is any question or comment from audience?
Thank you very much, Ali. Was really a very difficult presentation, very technical, but very challenging for all electrophysiologists. My question is a little bit clinical. Can your model help to predict the response to antiarrhythmic drugs?
Oh, yes, definitely. But we have to be careful that in the modeling, sky is the limit, but we have to stick to physiological conditions. And I tried several times when I was at Edinburgh with the Dr. Williams group. I tried several times to simulate the effect of antiarrhythmic drugs. The problem is that we don't have enough data. So, for example, I was trying to simulate the effect of flecainide, sodium channel blocker, on atrial fibrillation, and I wanted to see whether this can stop atrial fibrillation in simulation. But then I could not find a solid data showing how the sodium channel blocker, especially flecainide, affect the action potential and which channels was affected by the presence of the flecainide. So we can definitely model this, but we need better data and we need a more solid database to closely and in a precise way we can simulate what happens during the presence of antiarrhythmic drugs.
I have another question. It's maybe conduction velocity is not homogeneous in the human whole due to some arrangement of the microfiber, such as maybe it's very different between the anterior wall and the posterior wall of the atrium. So you can consider about such kind of heterogeneous conduction of the myocardic myofiber.
Yeah, indeed, that's true. So in this study, we augmented our model with fiber orientation. So we knew the information about the fiber orientation. So this factor has been in we thought about it for running this study. So it's already in the study. However, I agree that heterogeneity on the sodium channel on sodium channels may affect our results. And then this hasn't been considered in our study. And this is also due to the fact that the data is also very sparse about the distribution of the sodium channels conductivities among the different regions of the atria.
Thank you very much.